Welcome to the Health System CIO show. I'm your host, founder, and editor-in-chief, Anthony Guerra. On today's episode, I'll be speaking with Penn State Health's Dr. Chris DeFlitch, VP and CMIO, and Dr. Shadi Hijjawi, Associate CMIO. Gentlemen, thanks for joining me today.
Thanks for having us, Anthony. Much appreciated, man.
Thank you. Thanks.
All right, excellent. Dr. Hijawi, let's start off. If I'll go to both of you. We'll start with you, Dr. DeFlitch. If you want to give me a little bit of an overview of Penn State Health, and then your role, and we'll go from there.
Yeah, sounds good. Anthony, thanks for having us. So I'm Chris. I'm an emergency physician. I've been doing it for longer than I care to say. My beard's getting a little white, so I don't know if that tells you anything. I've been practicing emergency medicine for about 30 years now after doing some training up in Massachusetts, growing up in Pittsburgh, been at Penn State for almost 30 years. I'm a professor in the College of Medicine, still practice in emergency medicine, but actually the reason why we're talking here is I'm the Chief Medical Information Officer. So I started off doing that stuff before there was such things as CMIOs. So way back in the day when you were the physician champion for this or whatever, as some of us remember, back when we were trying to figure out this EMR thing going to work or not, right? And we're going to talk a little bit about AI. It's a whole other world we're into. And luckily, I've been here where Penn State, started off as Hershey Medical Center and as a College of Medicine right here in Hershey, Pennsylvania, has grown to a 7-hospital system across Pennsylvania, good partnerships with lots of folks across here to become a true Penn State health system.
All right, very good, Chris. I guess we'll go with Chris since you said it. So
there you go. It's all good.
All right, Shadi?
Yes, thank you, Anthony. It's really a pleasure to be with you, and thanks for having us again. So my name is Shadi. I am a internal medicine hospitalist. So I still practice hospital medicine at Hershey Medical Center at Penn State Health. So I've trained in, as I mentioned, internal medicine, but I have the passion around taking care of patients in the acute care setting. So I've been practicing hospital medicine for more than, well, not as long as Chris was saying. How long?
Shadi, you're making me old. Jeez, come on, man.
So yeah, it's been almost now 15 years. But I really, throughout the practice, grew a very deep passion towards system-based care and the things that mostly roll around EHRs and EHR transitions. So through different organizations, had to deal with the EMRs. I got engaged in one of those transitions, which attracted me to clinical informatics. I think a lot of those who are in this role currently, most of those like the CMIOs or associate CMIOs, they come with this practice-based background. The whole concept of training in clinical informatics as a specialty just were introduced maybe 10 years ago, where there's a board certification. So this is how I've became more passionate about practicing clinical informatics. What really interests me the most is applied clinical informatics. So as a practicing clinician or physician, I always think from this practicality lens, how this is going to be helpful or not. So again, this is my passion. I joined Penn State Health now 5 years ago as a associate CMIO.
All right, excellent, very good. So, Shadi, you co-authored a systemic review and meta-analysis looking at physician perceptions of AI. And it's sort of the genesis of our conversation here today. So do you want to, we're going to use that as kind of a jumping off point for a larger discussion, but what were some of the high points or the findings of the paper?
That's right, Anthony. I'm glad that post I put on LinkedIn on this drew your attention. So thanks so much for reaching out. I believe this topic is an area of interest for everyone here, at least, and I think a lot of your viewers and audience. So yes, I had the pleasure to participate to co-author a meta-analysis and systematic review of literature with translating AI to the bedside with physician buy-in. Again, the practical perspective, how this new trend, this concept is going to really be utilized by our clinicians mainly our physicians at the bedside. So it really highlighted the importance of knowledge and awareness of the AI, and it stated a few barriers that needs to be taken into consideration to be able to accomplish this adoption. From, as mentioned, number one, awareness and knowledge. Number two, the importance of engagement of these clinicians with the early design and development of tools in general. Specifically here, we're talking about AI. The need for clarification of the legal uncertainties that could be a barrier for these adopters, and the importance of learning from prior experiences of implementation of clinical decision support systems, and how we could not replicate the same problems we have with the EHR, grown CDS systems. And finally, to have an important patient-centric, perspective when it comes to the implementation of these tools, that we need to communicate with the patients and make sure that these tools are going to make things easier and better for the patient, clinician, physician interaction.
Okay, very good. Chris, any thoughts when you saw the findings coming out of that paper? Any impressions?
Yeah, I think, there's a lot to talk about here, Anthony. I mean, we could go for a long time, but let's try and stay focused maybe a little bit on sort of the impact to care, right? And at the end of the day, we're trying to figure out how does technology impact how we care for people. People get sick of me saying this, but healthcare is about people taking care of people. At the end of the day, that's what it's about, right? And so what we've done in healthcare, when I first started doing this 30 years ago, is we started throwing these EMRs out at people, right? And there used to be 1,000 EMRs out there, and now there's maybe 2 or 3 that are thinking, over the landscape, without legislation, without requirements, without interoperability. All that stuff was the Wild West. We're in that same space with AI right now, right? So there's just a lot of tech being thrown at things, and say, what does it mean for us, and how do we do it? And I think, Shadi's point about the applied informatics approach to things, which is, how do we help people take care of people, and where does the technology fit into that space? It was, I think, very fascinating, and sort of that warning, I guess, if you will. Warning may be a little strong, but maybe guidance to say, what makes sense for healthcare in AI, and what makes, risk for healthcare? Because, I think, people use terms like, technology is not the answer to everything. It's not a calculator. It doesn't give you the answer to the question, right? It provides with information, maybe some guidance or ideas, but it's just guidance and ideas. It's not really the answer to the question.
Yeah, and then sometimes it's surfacing something that you didn't know. And
Absolutely.
that's beautiful, right?
Absolutely.
That's wonderful. Oh, you didn't know this because it was way deep in the chart and you would have never gotten to it. But hey, this might be important based on the context. Like, that's very helpful, I would imagine.
And I think that's really the important part of it. Is there's a lot of value here. Okay, so don't get me wrong. I think there is absolute value in the tools that are being used, whether the EMRs or the EMR develops the AI or a third party develops it, doesn't matter. It's how you use the tools and technology. So if I can be, as I'm making a decision, working with a patient in the emergency department, and wants to surface some information to me that might be available in the literature, great.
Right.
If it wants to surface information to me that may be available in a chart, or better yet, in another chart in some other system that interoperably then provides additional information to me, awesome. But it shouldn't prescribe, right? It shouldn't tell you. It should say, here's more information. And I think that's where, we as clinicians, we as physicians especially, have the obligation to use these tools, but the obligation to use these tools for the care of the patient, not for all the other stuff that it may be used for.
Yeah, it's kind of interesting as you were talking. I do like the analogy of thinking of these tools somewhat as a secondary brain. Like you can develop them to the point that it's almost like you've got another brain that's helping your brain. But I think the important point you made is that it can't be equal. It's got to be down here, and your main brain has to make the final decisions, but it can be a supplementary type of brain. Does that
Yeah,
make any sense?
so I think it's a collaborative concept. Okay. So, what we do in clinical informatics is we bounce things off each other. Shadi and I work, hand in glove related to decision making for patients at the bedside and also for systems. And we say, two brains are better than one, 10 brains may be better than the other, but ultimately there's going to be a person who's going to make a decision. And
Right.
it's the patient who's going to be making the decision about their care with the information that we can provide for them, right? And
Yep.
so again, people taking care of people, collaborate, and if these tools can make it easier for collaboration, heck, if they can take away some of the administrative burden, 100%. But let's really focus in on the care and the outcome of the patient as the guiding principle.
Yeah, Shadi, you talked about your love for applied informatics, and that you really want to see how these things work in practice. And that's kind of the most interesting part. That's where we are. We've got these amazing tools that can do amazing things, but it's not sort of a plug and play, right? It's a work in progress. It's iterative improvement. It's sometimes two steps forward, one step back. And it's where that concept or that tool meets practice, and it's identifying first of all, you have to get it good enough to where when it meets practice it doesn't blow up practice, right? We know there's going to be some friction, but if you think about things and design them well enough ahead of time, you're hoping for minimal non-disruptive friction. You will have friction, and part of your job is identifying friction and removing it, but no one should expect perfection with something this novel out of the box. And I find that a lot of times when you get pushback from people on AI, it's because it doesn't have that calculator effect that Chris mentioned. They're expecting a calculator. It's not a calculator. So you have to set your expectations right. So wherever you want to go there, any thoughts you have about all that?
Yes. No, you're absolutely right. This is really a great question. And it starts basically of what problem we're trying to solve. So the same exact discussion you were just having with Chris. Am I lacking something? Is there something that will really help me and empower me and make me more efficient, make me more like compassionate with taking care of patients, trying to minimize all the things that it matters, but not as it matters as a clinician, as a physician, to take care of patient, to have this human interaction with your patient. So if anything that really makes this better, absolutely. But to your point, I mean, it's not a plug and play. It is, we're dealing here with humans with different perspectives, with different problems, with different things that they go on their mind, whether you're at the patient side of things or at the clinician, physician side of things. So technically having this understanding of the problem that you're trying to resolve there, and including the we say like one of the things that's really important with technology in general, but more with these AI, these very high tech, very empowered tools, that you need to consider this human centric design. You have to have a human centric design, and you have to keep this. There is a big science of a human computer interaction or interface. At that level, when you design these things, you need to make sure that they are going to be helpful than hindering in that process. And that's important. We talked about this with the clinical decision support and others. So it's really important if it surfaces these kind of information to me or helps me to do things like summarizing things that I need time to go and look and review to be able to summarize for patient care, for example, in the acute care setting where we do the hospital course, for example. It's very important to have it concise, relevant, put on the discharge summary for the primary care physician at the clinic to know exactly what happened, what did you do, why did you do it, and what do I need to take it from there. So having to be able to do that, it really is important to take in consideration the workflow of these humans, that they are interacting with the device, with the computer. They have a lot of things going off, trying to nudge them about ongoing problems with other patients, dealing with the patient in front of you, and dealing with the computer. It's really important to have a workflow attentive perspective with these different things that are being developed, designed to be at the fingertips, to be able to help and achieve what you're trying to achieve. So it's more of like, again, empowering than restricting, and again, all the friction that we know about with dealing with these different technologies and computers and EMRs.
Yeah, and it's interesting because we got to think about again, I'm going to bring my old guy perspective in this. You know, back in the 90s when we started doing this electronic record thing, it had all this promise of being better for this and better for that and better for this. I think there have been some components of where we've made a difference in healthcare and outcomes, but boy, we've added administrative burden like crazy, you know, from a technology perspective. And I think we've got to be careful about adding additional steps in the process, adding additional burden that are not beneficial to the patient, and add additional, challenges to the delivery system. The electronic record's done some great things, but it's done some challenging things too. So I just got to be careful about it.
Excellent. Yep. Great point. Um, so I was just thinking about some of the things that we're discussing here. And in informatics, we know what informatics is. It's knowing the tool, so the technology, and it's knowing the workflow, right? It's those, that's where the magic happens. It's that translator. I know the tool and I know the workflow. Um, and I was thinking that the speed at which AI is changing makes the idea of knowing the tool more challenging than it's ever been, right? Because you could be an expert on Epic, you could be an expert on Cerner, which is now Oracle, and you kind of had that. And then they had, releases would come out. It was all very manageable. The speed at which these AI tools are changing in their capabilities is daily, if not hourly, right? If you were to follow certain people on X who are considered experts in any particular LLM, you'll see a new guide every day, like based on their rollouts of the LLMs, what they roll
Yeah.
out. So you could do this, you could do that. Now you can do this, you can do that, and now set it up this way. So staying on top of that, being that expert on the tool, is more challenging than it's ever been. We assume that the general operations of clinical practice are fairly static, and they don't change very fast. But this stuff is changing at lightning speed. So for people like yourselves have to be in that role of translator, that's challenged. That's challenged to stay up on it, because sometimes you'll get pushback that may no longer be relevant. It could have been from a month ago, could be a misperception. So any thoughts there? Shadi, why don't you go first?
Yeah, so this is really important. Again, if you are bringing something, you only have one chance normally, especially with your interaction with very busy clinicians and physicians trying to save lives. If that chance is lost, unfortunately, you may not have a second chance. So it's really important to take in consideration, as we mentioned always, like the design, the deployment, the workflow attentive design. And that's why at our positions, trying to vet these things is very important and very existential. We have a lot of these different, mostly AI-based predictive models that's been in place for a long period of time, right? So the whole revolution came around generative AI and generative summative AI that has really made a big leap in technology and helping to summarize this like heavy amount of information, trying to streamline it, right? So trying to vet these things is not easy. That's why with all the competitive, like me and Chris, we talk about these things, trying to bring awareness about AI and practical uses of AI tools. And we talk about how more than 3 years ago, there were just a few ambient listening technology. And we basically at Penn State Health had trialed those that were EHR based or non-EHR based, and we saw where the problem was, and we did those pilots, and we learned from those pilots. We gave feedback. We've done that with other platforms like communication platforms and such. And having this ability to do these pilots and vet it, and have those that are engaged to help and give the feedback, and have the technology developer able to listen to make the changes. I think these are because as we said, like you could have something out of the box. It may be the greatest thing ever, but it's not gonna ever fit into the workflow to be helpful.
Chris?
Yeah, boy. Yeah, where do you go from here? Let's start with informatics. So, informatics sits in that space between the technology and the care delivery system, right? And so We understand how to deliver care, like, and all the folks that work with me at Penn State, they're all practicing physicians, right? They got to continue to practice because that's why we do things, right? We
Right.
take care of the patient. The understanding of the technology is there, but it is, as you said, moving very fast. I go back to say, you know what? We had a long run with Cerner. We were with them for 20 some years, right? Wonderful development, great company, did lots of sort of stuff here. We decided it was time to move into Epic. We're going to with Epic, great company, moving in that directions. But neither one of those companies solves everything, right?
Mm-hmm.
It's about how you deploy the systems to be able to apply to the healthcare. And what we're running into in AI is that there's lots of people developing lots of things, but what's the problem they're trying to solve? Okay. So to me, it gets back to why are we doing this? How can we help people take care of people? And what are the tools that are going to help us do so? I think, if you break AI, which is a very global concept, into sort of subsets, which is where we've tried to get to, is to say document generative AI from ambient listening has a lot of benefits. We tried one about 5 years ago, it failed. We tried one 2 years ago, it did okay. We're in the process of doing one now, it's actually flying, okay? So we know that the technology is developed to a point where it's actually helpful in people to decrease the amount of administrative burden and the documentation that's required, in the systems of healthcare today. Doesn't change how I take care of patients, just is reflective of the way I take care of patients. So that's a space. Decision support, as Shadi points out. Back in the day, we did this if, then, next statements, right? If you're allergic to penicillin and I prescribe you penicillin, please tell me not to prescribe penicillin, right? So it's a very linear thing. People are calling that AI nowadays, right? It's not really AI. It's decision support with some advanced things. But now it's not if, then, next. It's holy moly at a bunch of different levels with a neural network that's surfacing something else to you over a period of time. Now, again, you have to trust that information coming to you. So that's where the vetting of the different tools makes sense, which is where I think a piloting approach really is thoughtful, not just sort of willy-nilly allowing anybody to do anything out there with any stuff, but just to give them guidance and to understand that, hey, here's a tool. It may fit in this space to help you take care of patients. We think this probably is worth doing. Let's trial it. Hey, there's another tool here. We think it makes some sense. Let's look at it. Let's understand it best we can here. It's going to develop. We know there's some spaces in radiology, for instance, right, that that has decent evidence that says, show me some of these pixelizations of an image and give to me, there might be a high risk for an acute stroke in this scenario. I want to have you take a look at it quicker. Great. Boom, done. Top of my radar. I go and do that, and I probably make a difference for the care of the patient. So it's what problem are you trying to solve? There's a lot of technology out there that may make a difference, but don't go at the technology first. Go at the problem first and have the technology try and help you do better for your patients.
Excellent. Chris, something you mentioned just brought up a question to me. Do you think of a centralized IT function in a health system like yourselves as providing structure under which people can and operations and individuals can do their own things? Or do you think of it more as these pilots are things that we do, we run, and we get support for or we partner with, but essentially we run? So are you more of doing or are you more of structuring so others can do?
The answer to that question is yes.
Yep.
Because it really depends on what the scenario and situation is. I think we want to provide a structure, a scenario, and a function by which we can enhance the care delivery system. And I say that very explicitly because I think there are systems that you can put in place that enhances how the care is delivered. I'm not taking care of, millions of patients a year at Penn State Health. I'm taking care of my 35 patients per shift in the emergency department on Thursdays. Okay. So I have that primary responsibility during that period of time. And gosh darn it, I hope those systems help me provide that care for those 30 some patients during my shift. But also we do have that responsibility to say, how does that affect the urology department? How does that affect a neurosurgeon? How does that affect a primary care physician? How does that affect our patients who are searching for care for themselves when trying to determine who their primary care physician is going to be. So providing that support to our patients, providing the support to the people that are delivering the care, I think is our responsibility. We've got fiscal responsibilities as well, right? We can't just go out and just buy anything for anybody for any reasons, because that's not a good steward of our resources. And, oh, by the way, they have to be able to prove that it's going to make a difference, not that it's a bright, shiny object, but how does that help my physicians take care of the patient? How does that patient help themselves take care of themselves? How does it help that mom or that sister or that daughter who's taking care of the sick family member do a better job for it? And I think there's tools to do that. And I think there are companies, that do a good job. Epic, we're working through deploying that, and how their MyChart works and how they interact at the person level, I think is really going to be a big enhancement for us.
Excellent. Shadi, any thoughts?
Well, I mean, there's a lot of things to be mentioned here. It's like it's important to have the general structure, that you're open for new technology, for new ideas. I think you can tell, like, the way that these technologies, especially like we were talking about few vendors in a few years back, but now there's like more than 100 or one. Chris at some point was counting for our presentation. There's a ton of those, and trying to differentiate what makes one vendor better than another vendor, if we have to really leverage a third party, if we cannot really find that within our own EHR, because that's where the perspective, the specialty, the value, the clinical value that's going to bring to the table of having to deal with these things. So having the structure to be able to be open to what ideas that can be brought forward. I cannot tell you how many of our own clinicians, physicians have come to us and said, like, hey, there is this really great technology. Are you looking at that? Yes, of course. I mean, I think we've been really open for like a lot of different things where we are trying these at the bleeding edge of technology things. But at the same time, we were trying to take it in a conscious perspective that we need to see the value before we deploy that in a pilot or in a more like widespread use. I think, Chris maybe can talk more about this with the COVID, with the pandemic. There was a lot of different things from virtual care that I believe we have established a very impressive virtual care service line, or whatever you want to call it. And they've been running with a lot of different technologies that involves patient monitoring, devices, and things that could be based on LLMs or AI or others that, just brings value with their technology.
Yeah, Shadi, you bring up a point, because, I always talk about the patient driving their care, right? And how can we empower the patient to be at the center? And then the physicians and APPs and nurses and other people that are help taking care of the patient, that's good. But there is a role for technology and technology companies to innovate, right? So having those thoughts and ideas on the innovation, I think are wonderful. We're working with a number of companies who, are doing some very interesting thing in the behavioral health space and some other imaging spaces that, boy, they come up with some really good thoughts. And the goal is to provide better care, right? And so when they have that sort of patient at the center approach, I think there's a lot of benefit. Now, there are the healthcare systems and the business of healthcare there, and there's no doubt the technology can help ease that administrative burden for all those other folks who are working, to help the people who are helping the patient and to get all that administrative stuff and taken care of. But there's a balance between there, and that's where we're lucky to be in that space as informaticists, to be able to understand at least the concepts and ideas around technology, including artificial intelligence, summative, documenting, supportive, et cetera, and, still get to take care of patients.
Excellent. Excellent. I'd like to drill down a little bit into the area of sort of physician engagement. I think that's sort of a crux here, an important dynamic to making anything work in a health system, and especially around these technologies you're trying to roll out. Shadi, you said a couple of your findings from the paper were you got to engage physicians early, you have to educate them on the capabilities of the tools, and you want to include them in some decision points around maybe what tools or how they're going to be optimized or rolled out. You've got the idea of, the debate between personalization and customization. One is bad, the other one's good. You don't want to create systemic problems. So there's this point or this dynamic of physician engagement. I'm assuming there's a whole lot of physicians that don't want to be engaged. They just want to do their work, and they're like, "You just tell me what you picked, and I'm like, I don't care, right? Just you do it." And I would imagine there's a component that absolutely want to be engaged and consulted and will be very angry if they are not. So, and they're busy, 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 busy. The busiest people you're going to find in the world. You mentioned the dynamic of having one shot, maybe two if you're lucky, but sometimes one. If you really bumble and waste their time and aren't prepared for an engagement where maybe you get some one-on-one time and you're not ready or something goes wrong, you may not get another opportunity. And I believe that this dynamic is one of the most important. Getting this right is one of the most important things for IT individuals to do. If you blow this, if you're not good at this, I think you're dead, dead in the water. What have you learned about what type of engagement physicians need, how to do it, and some advice there you can give to others. So we'll start with you, Shadi, and then we'll go to you, Chris.
Yes. And I mean, Chris can bring more perspectives to what I'm gonna say. But one of the things that really amazed me when I joined Penn State Health, I remember in my first week there was this meeting that Chris holds for the health system, where we attract people who wants to change, who wants to be informed. These are practicing clinicians, physicians, providers that at least at this point we meet once monthly to share, to get an idea about what their thinking process really run very early before everyone else knows about certain things that the system is trying to consider or get their ideas. Like, what do you think? Ambient listening applications, they're coming right and left. There is no obviously control. There's a very interesting article that was just published about the tip of the iceberg. What we see with AI technology and trying to govern this is now, like, with the technology, with the accessibility, with the interest, it's very hard to govern these things. So if you don't if you're not more moving or thinking forward with this, trying to solicit ideas, to share ideas, that you're going to be behind in the game. So I think that's one of the important lessons we learned. I mean, in such organization as Penn State Health, we have, I think hundreds, if not thousands of physicians. And it's really important because at the end of the day, whether you want to be engaged or not, it affects you. I mean, this is what you're used. This is what's going to, if you work Monday through Friday, 8 to 5, this is a significant part of your life, and you need things that you can at least give the feedback. As informaticists, one of the things I've learned, and we did not get official training. Yes, maybe I became board certified by doing some readings and trying to get to some concepts that even hard to understand now with technology and data and such. But one of the things that you don't learn, whether you go to school or college or a course or whatever, is how to become attentive and the human interaction. Like, you need to learn to listen and to be patient, because people are vulnerable at the points of where they're ton of information, stress, etc. And this is what we learned from informatics. They need someone to hear, and not only that, but also it will be really amazing if you go back and say, we heard you. And here we are giving back based on feedback. So I think this is really important to leverage, not necessarily with AI or technology in general, but as a general approach.
Excellent. Chris?
We're lucky as physicians and residents and APPs to be able to take care of people, okay? And that's at the center of what we do. The adoption of technology it runs that gamut. Everybody's seen the bell curve where you got the early adopters and the people who run in at bright, shiny objects, and you got the laggards who've got their head in the sand and they ain't going to do it. Same thing is for physicians, nurses, APPs. Everybody follows that curve. I think Shadi's point is if you have the patient at the center, because patients come to Penn State Health to get great care by our physicians, okay? They don't come for any other reason other than to get great care, right? So if people understand that in the system and they value that interaction between the patient and the physician, everything else spawns from it, right? So we're lucky enough to be at that intersection where the technology is introduced into there. So that's a generic thing. But to answer your question, of course there's laggards. Of course there are people that aren't going to come along. Of course some people come kicking and screaming, right? But sometimes it takes a little bit longer for them to get to that space. I'll give you an example. We were using secure texting, okay, for an extended period of time. We brought a system in for years. It was like, I don't know. I like my pager. I like my pager. I like my pager. Now all of a sudden, we said, you know what? Technology and paging is not as reliable. Secure texting, Tiger Connect is a company we were using at the time, still using it now. And we've done 4.5 to 5 million texts a month. Okay, everybody's doing. We're going to move into a different direction and integrate it with Epic. Now all of a sudden, people are saying, "Oh my goodness, you're gonna move my cheese. Oh my goodness, I'm not gonna do this sort of stuff, right?" And the answer for us is, what's the best thing for you to do as a clinician? How can we best support you to move in taking care of the patient? So the integration with the EMR makes the most sense. Now, how do you do that? And what's the technology that does it? And is there a different interplay with it? That's where the informaticists come in and they can say, oh, that makes sense. Now, maybe I have to learn a little bit more technology than I really wanted to learn. Maybe I have to go into an area of clinical space that I'm not exactly perfectly, adept at, right? I mean, I created an ED without a waiting room, okay, back in the day, because I think systems can be made in place that you can get rid of waste. I'm a big, lean person who truly believes that healthcare is very wasteful and you can reduce waste pretty significantly inside here. And I think systems are the way to do it. And I think the technology is a way to enable that. But I also have seen over the years, technology can increase the amount of waste and increase the amount of administrative burden associated with it. So long story short, you gotta have a conversation with your peers that makes sense. We do that every Thursday with all of our physicians across Penn State Health. We do it every Tuesday with our physician leadership and our informatics leadership. So we're all kind of dovetailing to each other, and they say, hey, we're having troubles over here. Maybe we should start looking into something. Got it. Hey, we're doing really well over here. Oh, positive deviance. Let's find out from those people how they're doing it and why are they doing it. And can we extend that in some places? In some areas, we can't. In some areas, it is absolutely the best thing to do, and we learn from them as much as they learn from us.
Chris, I'd like to just give you another opportunity to talk a little more about this. You keep mentioning it, this dynamic of having humanity in healthcare and humans taking care of humans.
Yeah.
So it's a really interesting idea, of course. Um, Technology came around and was supposed to help this relationship, and it probably did to a certain extent. And then maybe it went overboard, and some of that's
Yeah.
government caused, where you have to fill in all these fields and
Yeah.
all that. So some of it was driven by regulation, some of it was suboptimal technology. But there's this other dynamic where technology may inhibit or hinder the person-to-person interaction at the moment, but the upside of the documentation can help the overall healthcare outcome because it's there, right? Whereas it might have been lost. So there's some of that. So we took the clinician, we hurt their ability to be human and to be present in the moment in a lot of ways. It seems like we have the potential now for AI to take over some of that administrative burden and give the human back to the patient in that interaction. That's what we're trying to do, I think. But it is always trying to perfect that marriage of support and help with being present. And again, as I mentioned, the AI tools are changing every day. So as you're trying to calibrate everything, everything's moving. It's just a fascinating dynamic. I'd like your thoughts.
Yeah, that's a lot there, Anthony. And of course, we're lucky to be in a stage of healthcare where we've realized what we've done to health
Yeah.
with the technology and are now trying to correct some of it. It'd be hard to go back to whenever I was a kid and I went to Dr. Cannon, who was my primary care physician, and actually I went and got my records as a kid, okay, and it said physical for football, okay to play. That was the documentation. Burn on thigh, second degree. Revisit, looking better. That was the entire documentation. Do you think he provided worse care for me? Nope, because he knew who I was, I knew who he was, and we had the relationship. It was a person taking care of a person. Now, all of a sudden, we've got these bigger systems where do you really have a primary care physician or do you have a primary care system? Do
Uh-huh.
you see the same person who can write on that piece of paper, I knew exactly what I saw last time? Or do you have a system? Part of our scenario is that we have these systems. And so we have to have some technology that supports that interaction just because of how our system is developed. Yes, we have increased the administrative burden exponentially to physicians from the time when I was a little kid back in the 70s to now, in 26. But we can do better. We will do better, right? So this ambient listening, I think, is a big step in the right direction. So instead of me looking at my computer and trying to get all of my administrative documentation done, I can actually listen to the patient, allow the tool to support me in a way. And I tell you, both our physicians and our patients feel that statistically in this iteration of our ambient AI deployment. In the previous two situations, it was hurtful. It did not do it. Okay. So that's where informaticists come in. They say, does this make sense or does it not make sense? You asked that technology vendor 5 years ago, of course it made sense to them. If you had the same different technology vendor 2 years ago, of course it made sense to them. But you got to prove it in real life. Okay. And so that's where that relationship that you have as informaticists with a technology and the technology companies and your IT systems and your patients and your physicians goes a long way. So I think that's where we're going to find that sweet spot is to be able to do it. It's going to continue. Healthcare is a business. Okay. It's a large chunk of our GDP. That's just the reality of our healthcare situation. Do I think we can make it less? 100%. Do I think we can make it more efficient? 100%. Do I think technology is in the middle of that? 100%. We've got to be willing to challenge things, though. I think there are opportunities for us to give technologies to patients, and this is a little controversial. I think there's ways to give technologies to patients that can enhance their decision-making. And I think they can enhance the conversations that they have for physicians, but it can't be overblown. It can't be Dr. Google, right? I can't go out there and search something and then whatever pops up at first that's sponsored for me is the right answer. I don't know, right? But there are people who do that. And we've run into that over the last 10 to 15 years that we're running into. Now, maybe there's some technology that makes a little bit more sense in their own context that can be helpful and additive to the conversation and not detract from it. But at the end of the day, different people who have the same disease may want a different outcome, right?
Yep.
So if you have, stage 4 cancer, you may be in that category that you want to fight every minute of every day. And no matter what, I'm going to go after it. That next person and that next visit for you as that oncologist may have the exact same disease with the exact same parameters and the exact same findings, but they may want to go in a different direction for their care, right?
Yep.
That's where the people taking care of people comes together with the technology. It's not about all those measured findings. One more thing, you brought up, there's a lot of data that exists out there, right? So we've been collecting stuff electronically for a long period of time. How much of that data is really accessible to improve the healthcare system? Not a lot, because for years it was put in different formats,
Right.
in different ways, and different structures. So, us as technologists, informaticists might say, this AI stuff, I can actually do natural language processing or OCM, optical character recognition, OCR, and bring it together. And all of a sudden I put it in a format that I can understand. And now I can process it in a way that makes sense. And now it's not just electronic stuff in, petabytes that are sitting out there. but it becomes information for me as the bedside clinician to actually use. We're in that transformative space right here. And all of a sudden, imagine there's a lot of things that, maybe could be managed at home that are pretty routine. That maybe could be managed with a test here and there that doesn't require a physician visit. And all of a sudden, you're changing the system based upon the technology. Now, the payment model's got to fall along with it. So that's a whole nother conversation. But I think the technology can enhance our delivery system in a way if we're willing to adjust in how the payment models are made.
Excellent, excellent. I'm gonna just give you guys one more question. We're about out of time. Shadi, I'm gonna go to you first, and then Chris, you can either add on to that or just give me your final thoughts. Um, Based on everything we've been discussing, it seems to me we talked about the physician dynamic as being super important. One of the other areas that I think is going to be super important, and we've talked about doing your research as much as possible to make sure that when you go forward with a pilot or a technology or a design or anything in this area, that you're close. You've done some research and you think you're close. You're not going to completely blow it. You don't roll it out and people are like, what was that? That was awful. So you're going to be close. You're going to try. You're going to do pilots. You're going to do iteration. But as I mentioned, with this whole dynamic, you would think you're still sometimes not going to get it right because of how quickly things are changing. You're going to be nimble. You know that concept of fail fast, right? Fail fast, try again. So you don't want to get risk averse. You want to do your homework, but some things aren't going to work out. You're going to have to pull the plug on some pilots. Some pilots you're going to say, we're done. We're done. It didn't work. Is that seems like a critical element here. I'd like your thoughts, Shadi.
No, that's absolutely right. I mean, you cannot just be very, very careful and restrictive, and because you're going to be like just sitting in the back. I mean, with the pace of how things are going fast with technology and things around requirements and what actually matters at the end. I mean, what Chris has mentioned, I think we're not that far apart from each other. I remember with those, like going to the doctor and saying like, okay, this is good, or this is like, the documentation was just the summary of things. Then it's morely what matters, what the patient needs, what patient care is, what is that really matters. So with that part in mind, you cannot just sit there. You need to continue to work, explore, and to your point, you have to pivot. I mean, if this something that did not work out, that's it. That's not the end of the world.
Right.
Actually, you are really applauded about trying and being open to what really matters, how things will help. What is the problem you're trying to solve? Again, two big things we always focus at. What is the problem and how that can help the patient, how that can help the humans interact in a better way with each other. So you're absolutely right. We do the due diligence. We try from an academic perspective to always that mindset of academic outcome of things. So yes, we focus on the practical implementation and the practical aspects of technology and informatics, but as much we always are concerned about the academic output of this, how we could analyze things and make sure that they really are meaningful. So we can bring this to the greater community and they can value that. So that's where we do things. I think it's absolutely right. You have to be nimble. You have, if anyone is just sitting in the back and thinking that, okay, I'm going to be the last one to join the party, it might be too late. And the way I think AI, is that it's something here to stay. It's not something that we're going to abandon or go back with. I mean, I don't think it's something that's going to replace. We always get those questions. Do you think this will be replaced? That will be replaced? I don't think so. I mean, although despite all the things that comes and all new technology saying, like one of the newest technologies is saying that, okay, we produced this new robots that's going to replace surgeons, for example. Well, robotics, they exist. And a lot of our surgeons, they use those things, and
right.
It makes them more efficient, more precise, less complications. So having more empowered robotics, that's great, but that's not gonna really replace a human being with a human touch, with a human attention. Despite all the things that a human could, like, forgetfulness or whatever, we still that the human touch and the human perspective is really important. And it's whether you're going to be the one who is really empowered by using AI or the one who's not using it. So as I said, it's here to stay. You just decide whether you don't want to be using it or the one who's using it and making the clinical value out of it.
Excellent. Chris, we're going to give you the final thought. We're about out of time, but great talk today. Go ahead, Chris.
Yeah, and thanks for having Penn State join you, Anthony. Shadi's just an amazing partner here, and I appreciate it. I'll leave you with this: is I think that the AI is here to stay. I think that AI as an adjunct to decision making is really going to enhance the way we deliver systems. I would ask, as we think about our learners, and as they are becoming physicians, or APPs, or residents, or nurses, or whatever, that they develop that critical thinking first. Have the problem understood first. Understand that, of course, first, and use the technology to enhance that human interaction that they're having with the patient. But you've got to have that. How do you ask the first couple of questions? How do you listen with that thoughtful and caring ear to then be able to take your personal knowledge and the knowledge of your partners like Shadi, and then the knowledge of AI, and bring it together for the best care of the patient? Okay, so I think we should not rely on it as a decision maker, but rely on it as a decision enhancer. But we've got to, especially in our next generation of learners, ensure the critical thinking remains.
Excellent, gentlemen. This was an absolutely wonderful conversation. I really, really enjoyed it. I want to thank you for your time, and I hope I can catch up with you again down the road.
Thanks for having us, Anthony. Much appreciated.
Thank you so much.
Take
Thank
care.
you.
Thank you. Bye.
Bye-bye.